Hello guys. Um, this is Dr. T. This is clinical medicine with Dr. T. So, guys, I want us to start now talking about the actual disorders, the actual psychiatric conditions. For the past week, we have just been talking about signs and symptoms that we expect in patients that are said to be having a psychiatric illness. So now today we're gonna start with psychotic disorders. So guys, what I'm gonna advise you to do to make psychiatry simpler, I would advise you to study signs and symptoms according to umbrellas. When I say umbrella, this is what I mean. If someone has got a mood and affect, study the symptoms that you expect under mood disorders, and then come to like psychotic disorders. Study the symptoms that you expect under that umbrella. This is one umbrella. I'm gonna call it an umbrella, guys, ne? And then you come to anxiety. Study the symptoms that are related to anxiety disorders. And then come to personality disorders. Do the same. Sleep-wake disorders, eating disorders, do the same. Study the symptoms. This is why this is important. When you have a patient or you have a case that you have been given, and then they tell you about the symptoms of the patient, you will listen to the symptoms and quickly decide, are you dealing with a psychotic disorder? Are you dealing with a mood disorder? Are you dealing with an anxiety disorder? Are you dealing with a personality problem? Like that. But you have not committed to a diagnosis. But what you know is that you have got a patient that you can, from what you are hearing from the patient and the relatives or your examiner, you can safely say this patient has got has got psychotic symptoms, or this patient has got anxiety symptoms. Now, after knowing which umbrella the patient belongs to, you can start now to try and figure out the actual diagnosis. And most of the times, the symptoms are very similar to all these conditions. Hence, they are called anxiety symptoms. Hence, they are called anxiety disorders. Hence, they are called psychotic disorders. Hence, they are called mood disorders. It's because they share symptoms. They've got similar symptoms. Now, what's gonna help you to differentiate one condition from another within the same umbrella? In psychiatry, one thing that becomes very important is the duration of symptoms. Number one is duration of symptoms. Number two, the circumstances. And this is very applicable to anxiety disorders. I will show you now what I'm talking about. So the first umbrella that we're going to be talking about now is psychotic disorders. So these disorders, the DSM-5 now has sort of like changed the how they name them. They call them now schizophrenia spectrum plus other psychotic disorders. That's what they call it now. But it doesn't change the fact that these are psychotic disorders. Okay, what they've done, I'll show you what they've done. They have taken schizotypal, which is a personality disorder, and then they've put it there. They've also included catatonia. They've also included delusional disorder. But we're going to talk about those. So the approach is, okay, when do we suspect that the patient has got a psychotic disorder? This is what they call a 5-symptom domain. There's what they call a 5-symptom domain. So psychotic disorders, they share this 5-symptom domain. And these symptoms are delusions. And we know that a delusion is a thought content disorder. It's a thought content disorder. Hallucinations. And this is a perception or a perceptual disorder. And then we have disorganized behavior or motor, disorganized speech, and negative symptoms. So, my dear brothers, when we say someone has got psychotic symptoms, they must be having one or two of these. They must be having. When we speak about specific conditions under this umbrella of psychotic disorders, we are going to talk about how many do we need, and they must have been there for how long. Then that's when now we are differentiating one psychotic disorder from another. But generally speaking, these are the symptoms that a patient must have in order for us to say they've got a psychotic disorder. We might not know the actual diagnosis at this point, but because they've got these, then we can safely say they have got some kind of a psychotic disorder. We have not committed, but the fact that, guys, the fact that we can tell or we can commit and say this patient has got a psychotic disorder, it helps a lot. I mean, we are only left with about 10% of the work now. 90% is done, because it means first of all you are able, or you were able to listen to the patient's symptoms and put them under a correct umbrella. Once you do that, you know that, okay, I'm not dealing with a mood disorder here, or I'm not dealing with an anxiety disorder here, I'm not dealing with a neurocognitive disorder here, I'm not. So you know that you've got a psychotic disorder that you're dealing with. Now the next important thing is to know what the actual diagnosis. Ne? I don't know if I can over explain that. So, and then now we speak about negative symptoms. What are the negative symptoms? Negative symptoms include what they call alogia, avolition, So basically it's a flat affect, the other A, then anhedonia, and then we have 1, 2, 3, 4. Then we've got asociality. These are called negative symptoms. You remember them by, they are called the 5 A's. Those are negative symptoms. We are gonna, for instance, maybe ask yourself, if these are negative symptoms, then which ones are positive symptoms? These are positive symptoms. These are positive symptoms. We'll talk about positive symptoms, negative symptoms, all those things later on. But now I want us to have a broad overview of psychotic disorders. So now we know that okay, maybe you're wondering, what are these terms? So elogia is a poverty of speech, basically, and anhedonia is someone who has lost pleasure in all previously pleasurable or enjoyable activities. Like, for instance, this is also a symptom of depression as well. So basically it's someone whom it's also found in depression, this symptom. So basically it's someone who, when they were well, before they said they got the symptoms or they developed the symptoms, say they loved to read, they loved to watch a certain TV program, or they loved TV, or they loved to go out and jog or play tennis, or they loved to read the newspaper, or they enjoyed baking, things like that. So now when they are sick now, even the things that brought positive energy in them, even the things that they enjoyed to the core, they don't enjoy them anymore, they don't do them anymore. That's anhedonia. Asociality is someone who's lost interest in social interactions. And then affect, as we know, they're not showing emotions. They're not expressing their emotions. And then avolition is so avolition is basically someone who, they just sit and do nothing. Like, they don't have a desire to initiate purposeful activities. They just want to sit and not do anything, basically. So those are the 5 A's of negative symptoms. So guys, I want you to spend time with this and make sure that you go over it and understand it, so that now when we talk about, because these symptoms are the symptoms that all psychotic disorders share. They share them. So if you know these symptoms, you understand them, then you will be able to pick the symptoms up from any given case scenario, or from any patient or relatives. And then the next thing, like I say, after that now, is to pinpoint the actual diagnosis. Yeah? Okay, now let's talk about what are the psychotic disorders that share these symptoms, signs and symptoms. Okay, so we've got brief psychotic disorder, a brief psychotic disorder. We have We have schizophreniform. We have schizophrenia. We have schizoaffective. Schizoaffective. This is a personality disorder. But now they've changed it and put it under psychotic disorders. And then we have delusional disorder. And then we have catatonia. I'll tell you something about these two. And then we have we've got psychotic disorders secondary to substance or medication. Then we have psychotic disorder secondary to another medical condition. And then we've got psychotic disorder not classified. So I hope you guys can see everything. Yes, okay. So if we can look at, because the signs and symptoms are those that we spoke about, so they share them. So what differentiates one condition from another, duration becomes very important. For us to say that a patient has got a brief psychotic disorder, it must be someone who's presenting with signs and symptoms of psychosis, number one. Number two, those signs and symptoms must be more than 1 day up to just less than a month. Some say a month. Schizophreniform is someone who is presenting with signs and symptoms that are related to psychosis, the ones that we spoke about, but it's more than 1 month, but less than 6 months. Schizophrenia. Okay, another thing that I wanted to mention here is that with a brief psychotic disorder, this is a retrospect kind of a diagnosis, because when someone is psychotic now, you don't know how long their symptoms. You can query if it's more than a day that probably it's a brief psychotic disorder, but if a month goes past, they get to second month, third month, then your diagnosis shifts to schizophreniform. If later, after 6 months, they are still symptomatic, then that's a schizophrenia. So for someone to have a brief psychotic disorder, it must be, so the duration of symptoms must be less than a month, and the patient must return to a complete level of functionality after the symptoms have subsided. Otherwise, if they are still symptomatic after a month, then it's not a brief psychotic disorder anymore. Then schizophrenia, symptoms more than 6 months. So this is how you differentiate it. It's very simple, easy to differentiate one from another. Then schizoaffective, what makes it different from this, it's the affective part, which is a mood component, which we are going to talk about. So here you've got psychotic symptoms plus mood symptoms, right? Which is usually depressive mood symptoms. So this one is easy to differentiate. So this one, you don't need, you don't really need, you don't have to wait for months and everything. But we are going to talk about the 2 weeks. We are going to talk about each and every one of these. But I'm giving you now a snapshot so that we have a broad understanding. If you can get the first part that we have done and this, then psychotic disorders are going to be simple for you. So here we've got a psychotic component with a mood component. We don't have a mood component here. We don't have a mood component here. We don't have a mood component there. And then let's talk about the delusional disorder. What is a delusional disorder? A delusional disorder is someone who's got delusions. They've got delusions, but they don't have other symptoms. They don't have motor problems. They don't have a speech problem. They don't have perception problem. They just have delusions. So it's called a delusional disorder. And then catatonia. So if you can check these two conditions, they are like your one, I'm just trying to find the right words. They are restricted to one domain of symptoms. When someone has got hallucinations, have got delusions, then they've got two domains involved there, right? It's the perception disorder and a thought content disorder. When also they've got a motor problem, then that's or a behavioral problem, that's a third domain, right? But with these patients, their symptoms, it's only delusions, so it's only one domain. With these ones, it's only one domain. They don't have a speech problem, they don't have a disorganized behavior, they don't have hallucinations. So the only psychotic symptom they have is delusions. That's why they call it delusional disorder. Catatonia, same thing applies. They don't have any other symptoms except behavioral and motor symptoms. They don't have hallucinations, they don't have delusions, they don't have disordered speech. They just have, it's called catatonia or catatonic disorder. So someone who's got this, guys, this is the most common that we see. I think about 80% of our patients, their psychotic symptoms are substance induced. So sad, because it's actually self-inflicted. It's really, really so sad. Okay, so so you've got a psychotic patient who's portraying signs and symptoms of psychosis, and then you check their urine, you find that they've got some substances in the urine, then you can attribute their symptoms to a substance or a certain medication or a medical condition if you find anything. So basically, this is what they do. When a patient has got psychosis, when a patient has got psychotic signs and symptoms, what the doctor who sees the patient first will do, they will obviously examine the patient and say, okay, the patient's got a psychotic episode. So what they will do after that, they will investigate the patient. They will do blood. They will do urine. The reason why they do blood and urine, they want to actively rule these two out. Obviously, they will take the history and everything. And also, the blood that they will do will also try to help if they've got any underlying medical condition. Because remember, once you take a patient to psychiatry that has got medical problems, chances are that medical condition might be missed and then the patient demise from that. So you want to make sure that they are not sick. You want to make sure that if they need some other medical interventions, the casualty officer takes care of that and all of that. And also because psychiatrists, they want to focus on the psychiatry related condition. They don't want to now to be transfusing a patient who's got a low HP, to be giving antibiotics to a patient who's got a high white cell count, or so things like that. So you want to check these so that by the time you take the patient to the ward, you have screened any other thing, and then you know that, okay, the only thing that they have is substance, if it's substance, or they don't have any medical condition. We don't see a lot of psychotic disorders that are not related to substance. I would love to see one, but this part of South Africa, we don't see a lot of that. The main reason is substance, and cannabis is number one. Okay, guys. So we are gonna talk about. Maybe we might as well just talk about the things the bloods that you want to do. So the bloods that you want to do, we do an FBC, we do a UNE, we do a TSH, we do VIT B12, we do folate, we do NCC ELISA, we do RPR, we do, what else we do? We do CMP, we do, if I remember, the other blood tests that we do, I'll put them as a comment, but these are the ones that we do most of the times. And maybe we are going to talk about investigations on their own, and also with toxicology, urine toxicology, what are the things that they look for there, and all of that. So let's make this a separate topic altogether, so that I will go into detail. Our video is already long now, 26 minutes. That's very long. Okay, guys, thank you so much. Let's meet on another as we continue with these psychotic disorders. Thank you. Bye.